Hi, I'm Lorraine Sarreal. I am an adjunct clinical instructor at UT Health Science, Houston. I am an acute care nurse practitioner and currently work with neurosurgery at HCA Houston Healthcare in Clear Lake. Primary tumors, such as meningiomas and neuronomas, rarely become malignant. However, there are gliomas, which are the most frequent brain tumors that can exist in 4 grades. Tumors are classified internationally according to the World Health Organization, or WHO. Tumors are usually graded by the way they look under the microscope. Grade 1, the tissue is benign. The cells nearly look like normal brain cells and are usually slow growing. Grade 2, the tissue is malignant. The cells look less like normal cells. Grade 3, the malignant tissue has cells that look very different and are actively growing, called anaplastic. In grade 4, the malignant tissue looks abnormal and tend to grow aggressively. The picture to the right is an example of an anaplastic tumor, WHO grade 3. Primary brain tumors originate in the brain tissue and are classified by the brain tissue in which they arise. The most common are gliomas, which begin in the glial cells. Some gliomas I'll go over in this PowerPoint include astrocytomas, which come from small star-shaped cells called astrocytes. These can grow anywhere in the brain or spinal cord. A grade 3 astrocytoma is called anaplastic astrocytoma, and a grade 4 is usually called glioblastoma multiforme. On a side note, GBMs are known to cross midline, as seen on the picture to the right. Another primary tumor called oligodendrogliomas are cells that produce myelin, the fatty covering that protects the nerves. These are usually in the cerebrum, grow slowly, and usually do not spread into surrounding brain tissue. Ependymomas develop in the lining of the ventricles and can occur in the spinal cord. There are other primary brain tumors that do not begin in the glial cells, and some of these include meningiomas. Meninges are dura mater that protect the central nervous system. These are usually benign. They are usually slow growing and become large before they cause symptoms. These are more common in women between ages of 30 to 50 years old. In the picture, you can see a little tail on the bottom right that comes from the meninges, or dura. Schwannomas arise from Schwann cells, which produce myelin that protects peripheral nerves. These tumors affect females twice as often as they do males. The picture shows the tumor affecting a trigeminal nerve. Craniopharyngiomas develop near the pituitary gland near the hypothalamus. These are usually benign, but can be considered malignant because they can cause damage to the hypothalamus or other vital organs. They most commonly occur in the suprasellar area of the brain near the pituitary gland and the optic nerves. Another important thing to remember regarding pituitary tumors is visual field loss. The patient will slowly lose their peripheral vision due to compression that occurs on the optic chiasm. And most oftentimes, the patient doesn't even realize that they're losing their peripheral vision. A test that is often performed prior to tumor resection is called visual field perimetry. Secondary brain tumors are tumors caused from cancer that originates in another part of the body and spreads to the brain, called metastasis. Cancer that spreads to the brain is the same disease and has the same name as the original primary cancer. For example, if lung cancer spreads to the brain, the disease is called metastatic lung cancer because the cells in the secondary tumor, in this case the brain, resemble abnormal lung cells and do not look like abnormal brain cells under the microscope. This slide is just to make you aware that there are differences between childhood brain tumors and adult brain tumors. As a brain tumor grows, it creates pressure on the brain called mass effect and changes in the function of the surrounding brain tissue. This causes multiple signs and symptoms depending on the location of the tumor. Some symptoms include, but are not limited to, headache, slight or severe, weakness to one side of the body, gait abnormalities, memory deficits, speech impairments, expressive, receptive, or global aphasia, seizures, grand mal or subclinical seizures, visual and hearing deficits. The left hemisphere of the brain is the dominant hemisphere for 90% of humans, making them right-handed, and the other 10% of humans are left-handed. This is called cross-lateralized behavior. In other words, the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. Along with this motor behavior, language is one of the most lateralized functions in the human body. Studies have shown 90% of the population are left brain dominant for language. For the left-handers, only 7% have right hemisphere dominance, and there's only 1% of the population that are right hemisphere dominant for both language and handedness. In short, a tumor in the Broca's area or Wernicke's area will most often be the dominant hemisphere in most humans. The symptoms will present as aphasia, whether expressive or receptive, and in extreme cases, global aphasia. These symptoms can be present whether this location of the brain is being invaded by a tumor, ischemic stroke, hemorrhagic stroke, AVM, or an abscess. Another example of tumor location and possible symptoms is when you have a tumor that is located in the motor cortex. A patient that presents with a tumor invading the left side of the brain in the area of the motor cortex can present with right-sided weakness in either the upper extremity, lower extremities, or both. When a patient presents with neurological symptoms, diagnostics usually begins with a CT head without contrast. If the CT head is suspicious for tumor, then an MRI with and without contrast is usually ordered. Neurosurgery prefers stealth protocol or a possible DTI protocol, which is software we'll talk about later. A tumor can never be 100% diagnosed via imaging. The brain tumor must be biopsied, or if a primary tumor is located elsewhere, it can be biopsied as well. When a patient comes in with neurological symptoms, the first thing a practitioner rules out is stroke, hemorrhagic or ischemic. A CT of the head has high sensitivity, 91 to 98% for detecting blood. Some tumors can bleed and is called hemorrhagic tumor. On CT, blood shows up as bright white. A suspected tumor will have a more defined margin, often circular in shape, and often present with surrounding vasogenic edema, which is a gray margin around the white enhancing area. In this slide, I just wanted you to see the other bleeding patterns so you can compare them to the hemorrhagic tumor. An epidural hematoma caused by trauma are usually arterial in origin and can be life-threatening, especially if the hemorrhage is located in the temporal region. The hemorrhage can push on the uncus, and surgery would be required to remove the clot. Subdural hematomas occur when the blood vessels, usually veins, rupture, most commonly from trauma. Intraventricular bleeding into the brain ventricular system, where the cerebral spinal fluid is produced and circulates to the subarachnoid space. This can result from trauma or hemorrhagic stroke. Spontaneous subarachnoid hemorrhage, as seen on the bottom left, is from an aneurysm rupture. If it is an aneurysmal rupture, you'll often see the starfish pattern. On the bottom right, you see another subarachnoid hemorrhage. Subarachnoid hemorrhage can also be caused from trauma and not an aneurysm, which is called traumatic subarachnoid hemorrhage. The most common cause of subarachnoid hemorrhage is due to trauma. Once a tumor is suspected, an MRI brain with and without contrast is usually ordered. Detection of brain tumors via MRI with and without contrast enhancement is a standard method providing excellent sensitivity, 93%, but not necessarily specificity of 82%. The different windows that pop up in the MRI highlight different parts of the tumor, but the most important to remember is the FLAIR or T2 window, which will show edema, and the T1 with contrast window, which will show the hyperdense tumor. Always verify the patient's allergy to contrast. If the patient is allergic to contrast, gadolinium can possibly be used. Also, be sure to check the kidney function. Most institutions will not perform a contrasted study for a creatinine of greater than 1.4. Correction of kidney function may be done prior to obtaining the MRI with contrast. Also verify any metal in the body. A patient with a pacemaker or metal stent will most likely not be able to get the MRI. In this case, the neurosurgeon may opt for a CT head with and without contrast, which is less accurate and definitely last resort. Most neurosurgeons will order an MRI with and without contrast with stealth protocol. Stealth computer navigation is a system where the patient's MRI is uploaded into the computer. It is what the surgeon uses for navigation in the OR. It creates a 3D image of the brain, allowing the surgeon to pinpoint the exact location of the tumor. Another special computer program is called DTI, Diffusion Tensor Imaging. This type of scan shows the white matter tracts and the nerve pathways. This is crucial information when planning surgery to avoid damage to the eloquent areas. So, for example, if a tumor is lying within the Wernicke's or Broca's area, the neurosurgeon may order this software to see where the eloquent pathways are and tries to avoid them during surgery. Sometimes a surgeon can do an awake craniotomy to map out these delicate pathways. Metastatic workup is done to determine treatment. Another part of deciding cerebral tumor management is obtaining a CT of the chest, abdomen, and pelvis. If a primary tumor is found, it may be more logical to get a biopsy of the primary tumor, as it is usually less invasive than a cerebral tumor biopsy or resection. This can also help the oncologist in determining the ideal treatment. If a tumor is amenable to chemo or radiation, that is also taken into account before surgical resection. If a patient is symptomatic because of the tumor, the neurosurgeon can consider tumor resection anyway to help alleviate those symptoms and help reduce tumor burden for chemo or radiation. If cerebral tumor resection is done, the tissue is sent to the lab for final pathology. The oncologist's recommendation is also taken into account. If the life expectancy is less than about 3 months, then surgical resection is not usually recommended. There are times when surgical resection is done solely for palliative reasons. For example, lung cancer metastasis, that is non-small cell carcinoma, is usually not amenable to chemo or radiation. Then resection can be considered for palliative care. Low sodium concentrations in the blood can cause fluid to leak across the wall of the blood vessel and cause increased swelling in the brain. Hypertonic solutions decrease brain water and intracranial pressure while temporarily increasing systolic blood pressure and cardiac output. In the reverse, too high a sodium level can indicate dehydration. Hypoosmolar solutions such as dextrose and water reduce the sodium and increase brain water and increase intracranial pressure. So if your patient is a neurosurgery patient, always verify before starting a hypoosmolar product. And the answer most usually is no. Magnesium relaxes vascular smooth muscle, resulting in vasodilatation and increases cerebral blood flow. Low magnesium levels may, in theory, cause glutamatergic neurotransmission. This can lead to oxidative stress and neuronal cell death. For cerebral edema, corticosteroids are administered. Decadron is usually preferred over methylprednisolone. Patients are usually started on Decadron 4 mg q6 hours and after resection are tapered off depending on if there was a complete resection, which is usually verified by a repeat MRI brain with and without contrast post-op. If the tumor was partially resected, then the patient may require to be on steroids longer, most likely at a lower dose. Always remember to add an H2 blocker with any steroid use to protect the stomach, and be aware that glucose levels can elevate with steroid use along with the WBC count. Brain tissue is very sensitive. A tumor can be very irritating and cause seizures, so anticonvulsants are often given to patients with cerebral tumors. Be aware that the temporal lobe area are prone to seizures due to tumors, hemorrhages, AVMs, and abscesses. Note, patients may not always present with the classic seizures such as grand mal seizures. Your patient may have subclinical seizures. Symptoms may be small or subtle. They can present as uncontrollable jerking movements of the arms and legs or unconsciousness. Others can temporarily be confused, have a staring spell, cognitive or emotional symptoms such as fear, anxiety, or déjà vu. Recurrent seizures or subclinical seizures may require an increase in anticonvulsive medications. If a cerebral tumor blocks the water system, also known as a ventricular system, the patient may develop a buildup of that water or cerebral spinal fluid. This is called hydrocephalus. An intervention that can aid in reducing the hydrocephalus is an external ventricular drain placement. The EVD is a temporary measure for hydrocephalus. Slow draining is important. Rapid or over-draining can collapse the ventricle, pulling the brain tissue away from the dura, tearing the cortical veins, and leading to a subdural hematoma. So, clamping the drain when the patient is having increased pressure inside the ventricles, such as during straining during a BM, walking, PT, OT, or repositioning, and or transferring from the bed to CT scanner. A more permanent solution to an EVD is a ventriculoperitoneal shunt or VP shunt. It is surgically placed into the ventricles and attached to a catheter that is tunneled to the peritoneal cavity where the CSF is absorbed. Of course, this is not a cure for the obstructive lesion. In fact, it is just a temporary fix. 73-year-old male comes to the ER with complaints of dizziness times 2 weeks. He says he's unsteady when he's on his feet and he leans to the right. He reports falling a couple times. He denies headache, nausea, or vomiting or changes in vision. No pronator drift was elicited and only a mild headache. The patient's most notable symptoms was his abnormal left finger to nose, ataxic gait, and positive Romberg's. The CT head without contrast was concerning for multiple intracranial metastasis with surrounding edema. There was no hemorrhage seen. Severe extrinsic compression of the fourth ventricle by the edema with mild tonsil herniation, no hydrocephalus or buildup of CSF. The CT chest, abdomen, and pelvis showed a new 8 millimeter nodule in the left upper lobe. MRI brain with and without contrast with stealth protocol showed hemorrhagic and non-hemorrhagic intracranial metastasis. The largest metastasis is located in the right cerebellum. There was mass effect resulting in compression of the fourth ventricle and along the brainstem. Here's the comparison between CT and MRI T2 and MRI T1 post-contrast. These are all similar cuts in similar location of the brain. The imaging on the left is a CT of the head towards the bottom of the patient's brain. You can see the hypodense area on the bottom left of the picture, which is the right side of the patient. It is suspicious for tumor. The middle picture is of MRI, same cut as a CT. It is the T2 flare where you can see the circular area, the lighter gray area representing vasogenic edema. It is pushing the the middle of the brain, causing a mass effect resulting in compression of the fourth ventricle, pons, right middle, and superior cerebellar peduncles. The picture on the right is T1 post-contrast and highlights the cerebellar tumor nicely. The cerebellar region of the brain coordinates voluntary movements such as posture, balance, resulting in smooth and balanced activity. This lesion was the main cause for the patient's ataxic gait, his wobbling and falls. When there are multiple brain tumors, the tumor causing the most damage is the one that is considered for resection, because the surgeon can't take all of the tumors out, unfortunately. In this picture, we still have the same patient. Now we're scrolling up his imaging towards the center of the brain. On the picture in the middle, you can see the T2 flare. You'll see the vasogenic edema. On the image on the right, the T1 post-contrast, you can see another tumor on the left of the screen, which is the patient's right side. Again, same patient, we're continuing up the brain towards the top of the head. And on the CT on the left, you can't really tell that there are multiple tumors. It isn't until you get to the MRI that you see more vasogenic edema in the T2 flare, and it's definitely visualized in the T1 post-contrast image on the right. Now we're at the top of the brain, just to show you the multiple lesions dictated in the MRI report. After discussion with oncology, neurosurgery was able to take out the cerebellar mets to help reduce tumor burden. Pre-op orders included Decadron 4 milligrams IV Q6 hours along with Pepsid, and we always want to check coagulation prior to any neurosurgical intervention. Immediately post-op, the patient usually goes to ICU for strict blood pressure control. Neurosurgery usually likes blood pressure less than 130. Post-op day 1, after the CT head is done and there's no new hemorrhage and no new infarct, the blood pressure is usually liberalized to less than 150 systolic. We usually like to get the patient up with PT and OT. In this patient's case, no incentive spirometry due to the risk of the cerebellar CSF leak. The incision on the back of the head is usually the weakest area and is higher risk for leak. You want to avoid straining, so a good bowel regimen is recommended. On post-op day 3, the patient was stable to transfer to rehab. The incision to the back of the head had nylon sutures in place. No drainage or erythema were noted. Post-op wound care was given to the patient, as well as instructions to follow up with the neurosurgeon in 2 weeks. At that time, the sutures are de-seeded and the wound is looked at to make sure it's healed enough for radiation or chemo.